Good evening, everyone. Welcome on behalf of Association of the Child Neurology. We have another very interesting session on clinical neuroradiology discussion. And for this session, we have two excellent experts, one the pediatric neurologist and another being neuroradiologist. So this is a great combination of Dr. Mini and Dr. Bijoy. It's a great pleasure to introduce Dr. Mini. Madam is very well known among the pediatric neurology circle. Madam is a professor and of the Department of Pediatric Neurology at Government Medical College, Trivandrum. Madam had completed her DM Neurology and Fellowship in Epilepsy and EEG from Sri Chitra Tirunal Institute. Welcome, ma'am. Welcome, Dr. Mini. And in addition, I would also like to introduce Dr. Bijoy Thomas. And Dr. Bijoy is a professor and head of the Department of Imaging Sciences and Intervention Radiology at Sri Chitra Tirunal Institute, Trivandrum. And he has plenty of publications to his credit, and he has plenty of book chapters to his credit. He has done his clinical fellowship in pediatric neuroradiology. So with these words, I would welcome Dr. Mini and Dr. Bijoy, and we hand over the session to Dr. Mini. Thank you so much, ma'am. Thank you, sir.
Thank you.
Thank you.
Good evening, everybody. We will straight away go to the session. We have two residents who are our DM neurology residents, final year residents, Dr. Mary Neepen and Dr. Elizabeth Preeti Thomas. I would like to invite Mary Neepen for the discussion of the initial two cases, and followed by that, Dr. Elizabeth will be presenting the third case. So Mary can start the presentation now. Meanwhile, while they are presenting, if you have any queries, please share your queries or comments in the chat box. Thank you.
Madam, my screen is visible.
Yes, ma'am.
Good evening, everyone. Today, radiology, we will be discussing the first case of a 4-year-old girl who's a single-born child out of non-consanguineous parentage, and she was a term 39-weeker. She was an SGA baby, 1.8 kg, and had complications like thick meconium-stained amniotic fluid and perinatal depression, followed by respiratory distress, as well as neonatal alloimmune thrombocytopenia associated with a grade 4 intraventricular hemorrhage. And also during the newborn period itself, she was diagnosed to have bilateral total retinal detachment with vitreous hemorrhage, and a vitrectomy was done for that. And the newborn, the top screening, the CMV, the rubella IgG was positive, but the IgM results were not available, and the urine CMV was negative. She had developmental delay since birth. Head control was attained by 8 months, sitting with support by 10 months, bidextrous approach by 10 months, with no social smile and absent vision. CT was showing calcifications in basal ganglia, as well as in the parieto-occipital cortex, with multicystic parenchymal lesions, and was supposed to be as a sequelae of hypoxic ischemic encephalopathy or a parenchymal bleed. And she had regression of her milestones since 11 months of age after the onset of epileptic spasms. Spasms were controlled, occasional focal and generalized seizures continued, and she continued to have recurrent episodes of fever associated with respiratory infection and hospital admissions. On examination, she had microcephaly, bilateral corneal haziness, as well as prominent eyes. She didn't have any head control, no milestones were there. Axial hypotonia with bipyramidal signs were also present. No perception of light, absent menace reflex. Impaired hearing with BERA inconsistently and poorly formed waves. Raised transaminases with coarse liver echo texture on ultrasound, and anti-hepatitis C virus was positive. And she also had persisting fever spikes with a poor sensorium. And because of this complaint, because of fever spikes and poor sensorium, she was referred to the pediatric neurology department. And because of persisting fever, CSF study was done, and the cells were only 2, both lymphocytes, Protein was 462, glucose 52 with the corresponding 89 GRPS, CB-net and gram stain as well as culture and sensitivity were negative. Proceeding to MRI, T1 axial sections, the medulla, the lower part of the cerebellum were relatively normal, but from the next section, the cerebellar white matter hyperintensity is not visualized on the left side, and also the temporal white matter was showing hypointensity, which was extending to involve the subcortical U fibers as well, and there was a well-defined hypointense lesion in the brainstem in the pontine region, and a subtle hypointensities in the cerebellar white matter. Higher up, there was confluent T1 hypointensity all throughout the temporal white matter. Here also the cerebellar white matter is not that visualized on the left side, and higher sections, with the eyes, being an asymmetry between the right and the left with a hyperintense signal on T1. Higher up, the confluent hypointensities were noted with enlargement of the temporal bone, and cystic lesions were also there in the occipital cortex as well as in the gangliocapsular region in the left thalami. Higher sections showing well-defined cystic lesions in the parieto-occipital cortex bilaterally in the left thalami with asymmetric enlargement of the lateral ventricles and the cavum septum pellucidum. And the T1 hypointensity of the deep cerebral white matter is also visualized with probable white matter loss also, and also some deepening of sulci suggestive of cerebral atrophy. And there is asymmetric ventricular dilatation again here, and the cerebral white matter is showing a hypointensity on T1. Higher up, cystic lesions are there in the parietal cortex over the right side, and T1, it is white matter is predominantly hypointense. T2 axial sections, there is the normal hypointensity of the cerebellar white matter is not there. It is replaced by relatively symmetric white matter hyperintensities of the cerebellum as well as the brainstem. There is diffuse hyperintensity with the temporal white matter showing dysmyelination, that is confluent hyperintensity extending till the subcortical U fibers. The same in the higher sections also, with the lesion in the pons being almost of a cystic, that is CSF intensity, and also accompanied by diffuse hyperintensity of the brainstem, and the temporal horn dilatation and confluent hyperintensities of T2 in the temporal white matter as well as cystic lesions. Higher up also, cystic lesions in the parieto-occipital head region, as well as in the left gangliocapsular region, the right gangliocapsular region, the left thalamus, as well as hyperintensities in bilateral basal ganglia and confluent hyperintensities extending till the subcortical U fibers all throughout the deep cerebral white matter. The same here also. And well-defined cystic lesions in the right parietal cortex and confluent and symmetric T2 hyperintensities extending throughout the deep cerebral white matter. Post-contrast sections, they were showing ring enhancing, that is well-defined contrast enhancing lesions in the brainstem, cerebellar white matter, and also the temporal horn is also showing enhancement suggestive of ventriculitis. Gangliocapsular lesions are showing contrast enhancement. The basal ganglia is also showing contrast enhancement on the left. The same here also. SWA sequences showing gradient blooming in the brainstem, predominantly in the basal ganglia bilaterally, right more than left, as well as a gyral pattern of enhancement along the parieto-occipital head region, as well as in the subcortical white matter in the right frontal region. The same cortical enhancement, a gyral pattern of enhancement is seen in the parieto-occipital region, as well as in the deep white matter. The T2 SAT section confirming the presence of cyst in the temporal, parietal, and the occipital region, and the T2 flare sequences confirming flare suppressed signal in the cystic lesions. Almost CSF intensity is visualized in the parieto-occipital cyst. So this was a case of cystic lesions with temporal as well as non-temporal cyst along with this myelination and calcifications.
It's not
As a
that
gen-
enhancement, no? It is actually blooming, which you saw in. You use the word enhancement. It is not enhancement, right? Okay, with that, can you just tell your differential diagnosis rather than going into?
No, I have a question. How did you come to the conclusion that these are calcifications and not hemorrhage? Do you have a CT scan anytime or face
CT
image of this?
scan was recorded as having calcifications, sir, because it was a long-standing lesion. It was supposed to be a calcification, but
No, that may not be correct, because hemosiderin can actually exist in the brain for many years or even decades. But if you want to differentiate, probably you have to have best is to have a CT, or at least you should have a face images of the
face
SW.
images
So
are
this
not there, sir.
okay. So this, I don't know whether this is SW or a protein gradient, but without that we cannot be 100% sure that these are calcific lesions, especially when the patient had a neonatal stomy course, and there was some evidence that there might have been some hemorrhage.
Okay, sir. The old CT records were mentioning it as calcification, sir, but we haven't seen that actually, because the images were not there with the patient, and also the face sequences are not there, only the SW sequences.
Okay. I agree that you have correlated with the CT. Otherwise, it is pretty difficult actually to differentiate whether it is old hemosiderin or calcium.
Okay, sir.
So you can just mention about the clinical possibilities and then move on to the radiological and then correlate.
So the first clinical possibility we had was possibly a multicystic encephalomalacia, and with a possible hypoxic ischemic encephalopathy, but GM bleeds equally, with contrast enhancing lesions in basal ganglia brainstem as well as ventriculitis. And we were thinking in terms of tuberculous meningitis, considering the MR images of the patient. But subsequently, when her history was analyzed, the newborn period itself, she was an SGA baby with thrombocytopenia and intraparenchymal bleed. And the records, they were not confirming torch infection. CMV, urine CMV was definitely negative, but the IgM serology was not available. But subsequently, she had a developmental delay, microcephaly, followed by glaucoma and corneal caseness, recurrent episodes of fever with elevated liver enzymes, which turned out to be liver cirrhosis, early cirrhotic liver changes, with anti-HCV positive and HCV RNA PCR being negative. And subsequently, her MRI was showing frontotemporal white matter rarefaction with cyst, cerebral atrophy, as well as calcifications. So the clinical possibilities were first one, an infection for an already baby having NHIs equally, and the second differential was Aicardi-Gouttier syndrome.
This patient
And-
was a term baby, no? So what do you
Yes,
think is
ma'am.
the cause for retinal detachment or retinal
Because
of this patient?
the records were showing severe thrombocytopenia with less than 50,000 counts, and at that time, the sequences MRI were reported as intraparenchymal bleed. So the CNS bleed secondary to alloimmune thrombocytopenia was the working diagnosis during the newborn period. So that was consistent with both TORCH as well as Aicardi-Gouttier. But since the TORCH screening was negative and the baby was continuing to deteriorate with subsequent neuroregression, we thought in terms of Aicardi-Gouttier.
And why did you consider the possibility of tuberculous meningitis, not simply bacterial meningitis? Or
The baby was actually worked up for PU. She had received multiple antibiotics. And after that, these ring enhancing and contrast enhancing lesions were found. She was having cachexia. She was having grade 4 PEM also. And with that scenario, with persisting fever, having persisting cough, as well as these lesions, and cells being less with a high protein of 460, we thought in terms of tuberculous meningitis.
Were there any diffusion sequences available at that time?
Actually, I didn't take the diffusion sequences, sir, but there was no diffusion restriction for that.
Okay. So if you are thinking of a infective lesion, especially whether tuberculosis or even bacterial abscesses, you should, expect some diffusion restriction. Yeah.
There was no diffusion restriction, sir. That was a point against.
One important thing is that in tuberculosis, tuberculomas, even liquid calciating tuberculosis itself can produce diffusion restriction, need not be always abscess. So so diffusion is an important sequence to differentiate. And temporal cysts were there. So the differentials for a temporal cyst, like you rightly pointed out, it will be either CMV or Aicardi-Gouttier or Van Renap. So here in this, Van Renap is not at all a consideration. So your differentials are pretty okay, but anything else you want to comment?
Just from my side, I would like to ask Dr. Bijoy whether if there is a extensive HI intrapartum itself, or just prior to that, if there is a severe, because this baby had a thick meconium. So can that lead to ventricular hemorrhages, and later will that produce calcification?
So cystic change? The dystrophic calcification can come, but the problem is that here the cysts are all bulging. It is producing mass effect. Okay. So that is pretty rare in encephalomalacia and cystic encephalomalacia. You can see there will be always some amount of atrophy, and this will not bulge and enlarge like this. So there is some definitive cystic processes are going on, and most of the time cystic encephalomalacia it will be almost always of CSF intensity once liquefactive necrosis has happened and it's a long-standing lesion. Here, some of the cysts are not isointense to CSF; they are hyperintense to CSF. So I don't think the cystic encephalomalacia alone can actually account for these things, even though there was significant hypoxia ischemic in the neonatal period. So some other pathologies are actually going on, especially when you see that cystic encephalomalacia, why it is actually confined to parietal and bilateral temporal, and all these things are very difficult. So there is some patterning which is happening here. So hypoxia alone, I don't think we'll be able to explain all the findings.
Yes, sir. Will that present in the newborn neonatal MRI itself, this encephalomalacia and cystic change, or with
cystic change can come in very fast. So after hypoxia, very fast cystic encephalomalacia changes can come. Within probably weeks time, it will become collicative necrosis, and it will all liquefied with a very little astrocytic proliferation. You see flare hyperintensity not because of atrophy, it's not because of brain volume loss. It is because of the reactive astrocytosis, which is very unlikely in the newborn period, especially in the preterm period, because there is hardly any oligodendroglial precursor cells are injured. There is hardly any oligodendroglial glial response. So it will all become hypo on flare. So I think that way that the early appearance of cystic lesions will not roll out as cystic encephalomalacia changes. But here it is not like that. These cysts are persisting for some time and they are enlarging, and they are specifically located to areas, and it is even though there are multiple white matter lesions, extensive white matter lesions, and there is specific cyst in the basal ganglia, thalamus, and possibly gyral sort of calcification. In addition, there is central solid chunky calcification as well. So these things are a little odd for hypoxia alone.
Okay, Marin, you can proceed now.
There are some questions also from the audience. Can we consider isolated sulfate oxidase MOCOD or call for A1? And then can sulfate oxidase deficiency, molybdenum cofactor deficiency is a possibility in this case? These are the two questions. So, Marin, you want to answer?
Marin, you can answer. What is the presentation?
This clinical picture of molybdenum cofactor deficiency is one of severe neonatal seizures, intractable seizures, and usually during the newborn period there will not be cystic transformation, and then develops subsequently. But in this patient, there was no history of neonatal seizures, and the clinical picture.
Serum uric acid levels, do you have?
Yes, that was normal for this patient, madam. It was not low.
And second one was a call
for A1. Call for A1 usually presents with isolated porencephaly, but diffuse porencephaly, multiple lesions have also been described. But this sort of white matter dysmyelination is not usually associated with call for A1.
And also molybdenum cofactor is a differential for, at least on MR wise, it's a differential for severe hypoxia. But usually they will produce significant atrophy of the white matter, not like large enlarging cyst like this. So whatever we have seen is that late stages of molybdenum cofactor sulfate oxidase will produce more atrophy and like late sequelae of hypoxia, not like a cystic encephalomalacia or enlarging cyst like this. Col4A also can produce multiple infarcts like or hemorrhage like lesions. But again, this expanding cyst is a problem for me to consider all these things.
Okay, Meryl, carry on.
So the cerebroretinal microangiopathy with calcification and cyst, that was the last differential that we consider, because large temporal as well as non-temporal cyst has been described with this particular entity, and it is associated with CTC1 gene, that is autosomal recessive mutation with spectrum of disorders with microangiopathy affecting the brain, eyes, liver, intestine as well as bone. Retinal microangiopathy with bilateral retinal telangiectasia and exudates, liver showing cirrhosis as well as portal hypertension, osteopenia and bone fractures, intestinal bleed, sparse hair and dystrophic nails being the clinical features. And for our patient, microangiopathy was there, which was affecting brain, retinal microangiopathy and liver cirrhosis were present. And ultimately, the clinical exome revealed a CTC1 homozygous mutation in exon 13, and it was homozygous autosomal recessively inherited, and the parental Sankar confirmed that is the mother and the father were carriers. CTC1 was there in a heterozygous state, exon 13 deletion, and both of them were asymptomatic. So that concluded the first piece.
So what's your final diagnosis?
The neuroregression was attributed to a multi-system disorder that was because of the CTC1 gene autosomal recessively inherited CTC1 gene mutation that was causing a cerebroretinal microangiopathy with calcification and cyst. But that was possible.
It is COTS plus syndrome. But can you clinically differentiate between Lebrun syndrome and COTS plus?
Lebrun is not associated with systemic manifestations. It is an isolated cerebral microangiopathy that is causing large cystic lesions as well as calcifications, and the gene is also different.
Yeah, but the MR appearance is almost similar except for the retinal features. Yeah.
Yes.
Very good case. Any other questions from the audience? You can actually type in. Otherwise, we can go to, for the interest of time, we can go to the second case.
Do you want to conclude with anything in this, Meryl? You had 1 or 2 slides you were showing regarding the cyst and calcification. You had shown that. Okay.
Ma'am, I just skipped that.
Okay.
Should I show this, ma'am?
Yeah, I think you can show that.
You can show because you're prepared.
Okay. So a dysmyelinating lesion with temporal as well as extratemporal lobe involvement with the presence of calcification and cyst. This was the algorithm proposed by Vandernapp, madam, in her journal published in 2015. So if there is a temporal lobe swelling with temporal horn dilatation and cyst, the next thing will be to look for frontal gyral abnormalities. And if it is present, along with MR evidence of calcification with non-temporal lobe cyst as well, and presence of early cerebral atrophy, that will go in favor of Aicardi-Goutier syndrome. So that was the first thing. That was the first diagnosis that we considered also. And the second one, megalencephalic leukoencephalopathy with subcortical cyst, that was not considered in this particular case, because even though the temporal lobe swelling, the temporal lobe cyst, the frontal gyral abnormalities were described, MR evidence of calcification is highly unlikely for megalencephalic leukoencephalopathy with subcortical cyst. So that excluded the diagnosis. And the third one, CMV infection, that was excluded because of the presence of these large non-temporally located cysts. That is very unusual for a CMV infection. Only temporal lobe cyst with frontal gyral abnormalities and calcifications have been mentioned. Vanishing white matter is also a rare possibility because of the absence of calcifications, and also non-temporal lobe cyst as such is not mentioned. Only generalized rarefaction has been mentioned in vanishing white matter disease. And the next differential, that is without any temporal lobe cyst, whether if it is a predominantly non-temporal lobe cyst, the differentials will be COTS plus disease, that is otherwise known as cerebroretinal microangiopathy with calcification and cyst. That is our case. or an isolated LCC, that is leukoencephalopathy with calcification of cyst. The same it is known as Labrune syndrome, and that is the same MRI picture without any systemic manifestations. So this was a simplified approach. That is
another one more thing I want to add, because you have decided to give contrast. That's a good thing here. So contrast also excludes a lot of things like cystic encephalomalacia, all those things. So contrast limits will not be there. So you're thinking of either an infective or inflammatory pathology, rarely acardic Guthier or CODS plus. So that again excludes the other things which we are discussing, including molybdenum cofactor deficiency, COD4A and all. So that is one good thing. So another very important thing you have done here is they have decided to do a flare. Usually less than 2 years, you don't do a flare because it will be very difficult to interpret. But to differentiate between extreme hypo or demyelination versus a cyst formation, sometimes flare will be useful. Especially in this case, you can see some of the cysts were not completely flare suppressed. Another important thing is that the gradient sequence you have done, and if possible, we should also do a phase and try to differentiate. At least the smaller lesions can be differentiated. Lobular lesions can be differentiated based on phase, whether it's calcium or hemorrhage. Not all lesions may not be possible when the geometry is different. So these are the things we should. Another very important thing, when you see such things, it is always better to do one spectroscopy also, if possible, especially when you are thinking of a differential diagnosis of tuberculosis or infective lesions, and especially when they are enhancing.
So will this viral pattern helps us to exclude bleed? Will it favor a calcification?
Yeah, that suggests most likely this will be a cortical sort of this thing, very extremely difficult. But the problem is that there can be cortical lamina necrosis in dystrophy. So there can be a mineralization or there can be hemosiderin deposition. Sometimes there can be only gemicidocyte accumulation, not mineralization. So it is that alone will not exclude hemorrhage. The cortical lamina necrosis also can have the same finding.
Can you just now comment on the CSF finding which you got with the genetic report? Can you correlate that? Very high protein. What is your...
The genetic report is consistent with the cerebroretinal microangiopathy, and this microangiopathy is known to produce CSF exudates as well as protein level may be high in these patients. So that is the possible explanation.
Okay, carry on. The same thing can occur with the microangiopathy, can occur with the acardic Guthier, and that also you can get an elevated protein. So carry on.
One more thing I want to tell that when you talk about dysmyelination, now that term is not longer used now. So it will be either hypomyelination or a demyelination. So I think it is more acquired demyelination which is happening. Probably some amount of hypomyelination is also there. But dysmyelination term as such, I think people are reluctant to use now.
Okay. So shall I proceed with the next case?
Yeah, I think you can go to the next case.
So the second case, it's of a 3.5-year-old male child, second born to a third-degree consanguineous parentage, and he had a mild developmental delay that was followed by regression of milestones from the age of 2.5 years in the form of difficulty in running as well as walking. And he had a rapid deterioration over the past 1 month, that is, he lost his head control and had a reduced word output, but no seizures. Cognition was relatively preserved, but after an acute respiratory infection, that was also lost. The child didn't have any micro or macrocephaly. Fundus was normal, cranial nerves were normal, bilateral pyramidal signs were present, no cerebellar or extrapyramidal signs were present. His basic metabolic workup was within normal limits except for a mildly elevated lactate. T1 axial sections, the cerebellum and the medulla was relatively normal, and higher up there was T1 hypointensity that was visualized on either side of the midline corresponding to the region of the corticospinal tract in the pons. And the higher sections, there was also a faint hypointensity in the region of transverse pontine fibers, as well as higher sections were showing some hypointensity in the periventricular region. And higher up, the periventricular parieto-occipital deep white matter was showing hypointense signal. And the same was there in the deep periventricular white matter in the parieto-occipital region. T2 axial compared with T1 axial, there is this white matter hyperintensity that is seen with the corresponding T1 hypointensity and some faint hyperintensities over the left as well with corresponding hypointensities. And the lesions that were hypointense on T1 were hyperintense here in the pons, as well as the middle cerebellar peduncle is also showing fairly symmetric hyperintensities. And higher sections, the corticospinal tract, the location was showing hyperintensity in T2 with hyperintensities extending over the ventral aspect of the pons, as well as the same with hypointense on T1. And the higher sections confirming T1, T2 hyperintensities on the ventral aspect of pons. And the deep white matter was showing T2 hyperintensities almost in the region of optic radiations. Bilaterally, it was T2 hyperintense, fairly symmetric. And deep inside this hyperintensity, some cystic lesions, CSF intensity signals were also visualized, right more than left, here also. And the splenium of corpus callosum was showing a hyperintensity, almost CSF intensity, with cystic lesions in the white matter hyperintense lesions that were seen previously. And almost cystic changes were there in the periventricular white matter. And the splenium and the body of corpus callosum was showing hyperintense signals. And the periventricular white matter in the centrum semiovale is also showing faint hyperintensities, but it is limited. It is not spreading to the subcortical U fibers, and it is relatively parieto-occipital predominant. And the sagittal section is confirming the same. And the midline section, here the splenium is definitely in the CSF signal intensity. And on the anterior part, the genu is showing a middle blade, likely middle blade involvement of the corpus callosum. An upper part and a lower part sparing with involvement of the middle part, that is hyperintensity, is visualized. And there is a high signal over the ventral aspect of the pons, as well as the hyperintensity is extending throughout the cervical cord. Flare sections, the cerebellar hyperintensity is confirmed, as well as the hyperintense signals are there in bilateral MCP, as well as in the transverse, the ventral pons. Here also the transverse pontine fibers and the parieto-occipital white matter with cystic lesions, that is CSF signals are suppressed, as well as the splenium also there is suppression of signal, likely indicating cystic change, as well as cystic lesions in the parieto-occipital deep white matter. The same in the higher sections also. SWA sequences are not showing any blooming, and the DWI is showing restriction of the deep cerebellar white matter, and bilateral MCP signals are showing some diffusion restriction, patchy diffusion restriction, and the outer aspect of the signals are also showing, that is optic radiations are also showing by diffusion restriction. And same also in the higher sections. The periphery is showing diffusion restriction. Post-contrast sections, there is no contrast enhancement, and there is no garlanding or contrast enhancement for the parieto-occipital lesions.
Is there anything outside the skull which you have not described in the MR sequence?
Yes, ma'am. There is a bilateral maxillary sinus is showing flare as well as T2 hyperintensities.
And it's also producing diffusion restrictions, so some sinusitis is there.
So while managing the patient, everything will have to be considered together, not only the glaring findings, but the other things also will have to see. Okay, go on.
Okay. And the cervical cord is showing hyperintense signal on T2. And this is the MRS. MRS is showing at a low T, that is 30. There is a doublet that is upright, and on 135 TE, the same thing is getting inverted. So it is at 1.3 ppm, and since it is inverting at 135, it is likely to be a lactate peak. So to summarize, There were confluent T2 flare hyperintensities in bilateral posterior frontal, parietal and occipital periventricular, as well as deep white matter, with posterior body and splenium of corpus callosum involvement. Sorry, I missed to tell bilateral posterior limb of internal capsule involvement, pons, middle cerebellar peduncle, corticospinal tracts, and pons also getting involved. And these lesions were correspondingly T1 hypointense, sparing of subcortical U fibers, multiple cystic lesions in the peritrigonal region as well as splenium, diffusion restriction along the periphery of T2 hyperintense lesions, no post-contrast enhancement, spinal cord showing longitudinally extensive T2 hyperintensities in cervical and thoracolumbar region, and MRS showing a lactate peak. So the differential.
Yeah, can discuss the differentials.
The differential diagnoses that were considered were mitochondrial leukodystrophy, complex 2 or complex 3 and 4 defects, adrenoleukodystrophy, then LBSL. And mitochondrial leukodystrophy was considered as the first diagnostic possibility because of the presence of third-degree consanguinity, because an autosomally recessively inherited disease was suspected. The baby was having developmental delay with the motor regression following an infection, with severe deterioration, being bedbound, with language also lost. Complex 3 and 4 defects were suspected because MRI was showing parieto-occipital white matter hyperintensities with well-delineated cysts. Complex 2 defects because of the involvement of brainstem, middle cerebellar peduncle, and thalamic involvement was not seen in this case, or a combination of complex 2 and complex 3 and 4 defects is also possible. And with diffusion restriction, possible involvement of the middle plate of corpus callosum and lactate peak. The second differential, being a common diagnosis, adrenoleukodystrophy of childhood onset was considered because he was a boy, but he also had a motor regression followed by dysarthria and loss of language with bipyramidal signs. But there were no behavioral or visual problems, no hyperpigmentation or evidence of adrenal insufficiency. But the MRI picture, it was more or less suggestive that is T2 flare white matter hyperintensities were there in parieto-occipital region, corticospinal tract involvement was there in pons and medulla, splenium of corpus callosum, posterior limb of internal capsule involvement, middle cerebellar peduncle involvement, cervical cord hyperintensities were all in favor. And contrast enhancement was not seen, but that may not be present in all cases, and 50% of cases were there without any contrast enhancement. The third differential that was considered was LBSL, that is leukoencephalopathy with brainstem and spinal cord involvement. Not going into the diagnostic criteria because it was more or less periventricular white matter hyperintensities with involvement of the corticospinal tract as well as dorsal column. And as a broad differential for parieto-occipital lesions other than X-linked adrenoleukodystrophy, AARS2 related leukodystrophy that is also associated with cystic lesions, and that is also a mitochondrial leukodystrophy should be considered, and juvenile Krabbe, APOP-T1, APOP-T1 related leukodystrophy, mostly an adult onset leukodystrophy, and early onset peroxisomal disorders are the other differentials. And for this particular patient, we got a mutation that is STHA.
Can we go back to the imaging first? Our case. One or two things I wanted to confirm. Go back to the first. So very important thing. We see some T1 very hypointense lesions, especially corticospinal tract, and they're relatively iso to hypointense lesions also. Please go up.
You can point to what Dr. Bijoy is telling, Marin. So
yes,
that's
my pointer is not working. 1 second, ma'am.
Yeah. So we have some iso to hypointense and relatively really hypointense lesion, almost isointense to CSF in the ventricles. So that means some real cystic or encephalomalacic lesions are happening. And another very important thing Dr. Marin has actually pointed out. Go back. Just one slide back. So if you look at the splenium, the genu is relatively spared, but the splenium you can see the anterior and the posterior, or the superior and the inferior limbs are spared, and there is cystic, necrotic, or like lesion, or involvement of the middle blade of the corpus callosum is involved. That gives an important clue. So one of the other differentials I would think of is the vanishing white matter disease from this. But the cystic changes, I mean, it can happen, but not as the first episode itself. But in that case, the inferior blade of the corpus callosum is more involved. So when the middle blade is involved, sparing that the middle part is involved, sparing the superior and inferior blades, like she has shown in that sagittal section. So this is pretty much very characteristic of a mitochondrial disease. Another very important finding, even though patient didn't have any cerebellar findings, cerebellar folia are all prominent. There is cerebellar atrophy, and cerebral atrophy is also there. That is also pointing towards a mitochondrial thing. Then you see that the spinal cord involvement can come in mitochondrial, but most of the time, these cases are very difficult to do anesthesia because you cannot give actually gaseous anesthetic agents. In propofol anesthesia, they have to do very fast sequences, so they will not image spinal cord. So whatever is spinal cord is involved, you cannot actually immediately conclude that it's a DARS2 mutation or LBSL, even though it is also producing a cystic cavitating leukoencephalopathy. So we are considering a cavitating leukoencephalopathy. Go next. And another thing is that for every case, we need not have to give contrast, especially in the newborn period, because their EGFR is really less than 30. So giving contrast gadolinium, because a lot of case reports or articles are coming on effect of gadolinium deposition in the brain. So as far as possible in the neonatal period itself, unless your very pressing needs are there, contrast should be avoided. I agree that one of the differentials is adrenoleukodystrophy, and if there is enhancement, we can probably differentiate, but even without that, you can actually do. So very important finding go up in the T2 and the diffusion. There is relative sparing of the basal ganglia and more involvement of the central white matter and relative sparing of the subcortical leaf fiber. So in differentiating between, so we have pretty much concluded that this is possibly a mitochondrial disease because of all these things and because of the clinical presentation also. The nearest differential is definitely an LBSL because of the involvement, and we have seen lactate also. And then this is a cavitating leukoencephalopathy. And basal ganglia is relatively less involved, but post-limbo, the internal capsule, even optic radiations are involved. And then we have to think of which sort of mitochondrial disease it is. So which are the mitochondrial diseases which are producing a cavitating leukoencephalopathy, like she has clearly pointed out, it is the complex deficiencies, complex 1 to 4, but usually complex 1 to 5, or usually the commonest one will be complex 1 and complex 3 deficiencies. And complex 2 deficiency is extremely rare, but if you go to the next one, and the complex 4 usually will be like a SURF mutation and brainstem involvement with their basal ganglia sparing will be there. But spectroscopy, can you go back to the spectroscopy? There is more interesting finding in the spectroscopy. Go back.
Picked up by
yeah.
Dr. Bijoy only now telling. Okay.
Yeah. So you can see that there is lactate. In addition, there is another peak in the left of the glutamate, and which is again seeing in about T135. Lactase is inverting, and at 2.4 ppm, there is a peak which is succinate, which is a very large peak. You don't expect this tall peak in succinate. So that is very, very characteristic. So lactate, if it is seen in a lesional side, it carries no meaning. Any lesion which is T2 hyperintense can produce a lactate, there is a demyelination or this thing. So the other thing is when this succinate is seen, that is pretty much, we have to be very, very careful. So we are thinking that it is a cavitating leukoencephalopathy. It can be complex 1 to 4 or a multiple enzyme deficiency, or it can be something else. But when you're seeing succinate, so you have to strongly consider succinate dehydrogenase deficiency. You have to strongly consider complex 2 deficiency or multiple enzyme factor deficiency. So that is what this is not only lactate, here some succinate is also seen. So now we can, there were 2 other questions. Can iron sulfur cluster mitochondrial disorders produce such an imaging phenotype? Second question is, preservation of inner and outer blades of corpus callosum with the complete extent of corticospinal tract involvement is classical for SDS deficiency. See, there is these are the 2 things people have actually told. So I'm not very sure about SDS deficiency alone producing corpus, because we have seen any mitochondrial disease, especially these complex deficiencies, outer inner blade sparing and central white matter, and also multiple, especially multiple mitochondrial enzyme deficiencies. It is seen, not very specific for SDH, I think, but I think these are very important differentials. So now we can show that.
Dr. Kavita has asked one question: where should the oxal for MRS be placed? Probably.
Yeah, this is a very important question in mitochondrial diseases. So when you are the basal ganglia is not involved, at least we should place one voxel in the basal ganglia. When the basal ganglia is involved, at least if we can do multivoxel spectroscopy, at least part of the voxel should be there. Where uninvolved brain, or so-called by visual inspection by uninvolved brain, you have to have a spectrum. And if you see lactate there, especially in the ventricles also, so you can probably think that you are leading with a mitochondrial disease. But if lactate is seen in the lesional side, it can be any disease. But very important, picking up these subtle findings like succinate levels, that is very important. Then we can think of specific conditions. So other thing is that the iron sulfur cluster mitochondrial disorders produce such amazing phenotype. I think I'm not particularly sure about that. But this between these mitochondrial diseases, especially complex deficiencies, it is extremely difficult. The complex 1 and complex 3 and multiple enzyme deficiencies, you cannot differentiate. So it is, even though there were features which are described in the literature, but these mitochondrial disorders don't read papers, so they don't present like the way we want them to appear. So it is not very easy, but because of these constellation of findings, and especially with the clinical features, we can be pretty much sure that it is a mitochondrial disease. Most likely it's a cavitating leukoencephalopathy. So it most likely it is cytochrome or multiple enzyme deficiency. Because of succinate, we can be pretty sure that it is complex 2. There may be some problem.
And the genetic report also has come like that.
Genetic report was succinate dehydrogenase deficiency, that is STHAF1 mutation, which was seen in homozygous state, and that was confirming complex 2 deficiency nucleotide. And about the disease, it is a rare leukoencephalopathy, and the genetic mutations STHA, STHB, and STHAF1, and the MRI abnormalities, cerebral white matter abnormalities with sparing of nerve fibers, corpus callosum involvement with sparing of outer blades, corticospinal tract, thalami, and spinal cord involvement. And the MRS showing succinate peak. And this was the succinate peak that is seen at 2.4 ppm. And the treatment, clinical spectrum, that is the progression, it's an infantile onset neurological regression disorder with partial recovery and subsequent stabilization. Riboflavin is also recommended as beneficial in some of the case reports. Thank you.
So there were some other questions also. Can LBSL and DART mutation produce diffusion restriction lesions? I think theoretically yes, because they are also demyelinating lesions. But whatever we have seen will be usually in the chronic phase. We have not seen diffusion restriction in LBSL cases, whatever I have seen. And why is middle blade of corpus callosum affected in mitochondrial disorders and not predominantly in others? Reason for the differential corpus callosum in IEMs. I'm not very sure why that it involves the middle cerebral. If anybody knows, they can type in the answer. But middle blade is pretty much characteristic of mitochondrial, but inferior blade or inferior corpus callosum involvement is more suggestive of it is a vanishing white matter disease. So I don't know if anybody else, I mean, if anybody knows, I don't know why this happens, why the middle blade is involved.
Okay, then we can move on to the last session. Thank you, Merit, for that excellent presentation. Now, Elizabeth,
They've asked what is the follow-up of this child, this second child?
Second child, actually, we couldn't do the parental sancre, sir, and she belongs to Tamil Nadu, and he has not come for further follow-up.
So they are from the other state, Tamil Nadu. They have not come yet. Okay. So thank you, Merin. We can go to the second session after a totally different one from the cystic lesions of the brain. Elizabeth, you can start.
Ma'am, is my slides visible?
We have only some 10 minutes left, so we can go through as quickly as possible, Elizabeth. Okay.
Yes, ma'am.
In between.
So I'm presenting the neuroradiology of a 9-day-old baby boy who was born to a mother with recurrent first trimester abortions. And the baby was born as a late preterm at 36 weeks with a weight of 2.7 kg with good upgas and a normal head circumference. But the baby was noted to have a feeble cry at birth with hypotonia noted from day one itself. And the baby had refractory seizures and recurrent apnea from day one, and on examination was noted to have right element facial palsy, and the baby had frequent aspiration of feeds and difficulty in feeding with poor suck and was on RT feeds. So from the history, the baby was having hypotonia. So central versus peripheral in view of refractory seizures as well as facial palsy and probable bulbar symptoms, we were considering central causes of hypotonia, and probably in view of seizures, both cortical and also because of the facial palsy and the lower bulbar involvement, probable malformation of brainstem was suspected, and the MRI was taken. And this is a T1 axial sections from upper coming down. We can see that assessing the myelination for the age, that is 9-day-old baby, we can see hyperintensities along the peri-Rolandic cortex, which is normal for the age. But the posterior limb of internal capsule has not completely myelinated. The hyperintensity is not well seen. And going lower down, we can see that the midbrain is hyperintense, showing that the myelination is adequate for that age. So the peri-Rolandic cortex as well as the brain stem is appearing to be myelinated. Posterior limb of internal capsule has started myelination. And going further down, this is the lower part of the midbrain. This is a patient, our index case, and this is right side. On the right side is the normal MRI. So we can see this is the normal appearance of the lower part of the midbrain with the ventral convexity and a good differentiation between the tectum of the midbrain and the tegmentum. So we can see a good differentiation here. But in our case, the differentiation between the tectum and the tegmentum is poor. And the vermis we can see is more or less normal here. And the superior cerebellar peduncle is somehow thinned out. So going lower down, this is at the level of the middle cerebellar peduncle. We can see there is near total absence of middle cerebellar peduncle, and the ventral convexity, that is the bumps, the ventral bumps of the pons is totally lacking. There is a slight asymmetry also. And we can see this is the normal MRI at the level of middle cerebellar peduncle. Usually we need to see the cerebellar hemispheres very well as the fourth ventricle. Here we cannot actually see the cerebellar hemispheres. The middle cerebellar peduncle is not seen, and the ventral part of the pons is flattened asymmetrically, and the fourth ventricle is not seen. Going lower down at the level of medulla.
This is cerebellum also, no? Cerebellar hemispheres, previous one.
Yes, ma'am. Cerebellar hemispheres are not seen
at.
Sorry, ma'am, I didn't hear.
Now, what are the structures that you're seeing on either side of the brain stem then? Is it the cerebral hemispheres that you're seeing at this cut?
In this cut, we are not at all seeing cerebellar hemisphere, but the cerebral hemispheres. That is the temporal lobe and the occipital lobe is now occupying that area.
Okay, go on.
And lower down, we can see at the level of medulla, normally the medulla appears with a convexity in the front as well as in the back. So the normal morphology of the medulla is totally lost. It is also ventrally flat, and also the cerebellar hemispheres as seen in this normal MRI is not seen in our case. And also in the middle part, this is a normal appearance of the vermis. In our case, the vermis is hypoplastic. It is not properly seen. And also the morphology of the fourth ventricle is altered here. This is the normal appearance, and here it is altered. So this is a normal appearance of the cerebellar folia. The folia should be parallel to the calvarium, like onion peel. That is onion-like. It should be, the folia is always parallel to the calvarium. But in this case, we cannot actually appreciate the folial pattern here, but this is the normal appearance. So the ventral part of the medulla is formed by the pyramids as well as the inferior olivary nucleus, and probably the pyramids as well as the inferior olivary nucleus is the shape is altered here, either due to the involvement of either of them. So that was the axial sections. So from the axial sections, we have inferred that the myelination is adequate, almost adequate for the age, but there is significant brainstem abnormality with cerebellar hypoplasia. So to correctly assess the cerebellar or posterior fossa anomalies, we should assess the the mid-sagittal section. So taking into consideration the mid-sagittal section, here we can see this is a normal appearance. That is, the pons should be at least 1.5. This is a rule, 1:2:1. So the pons should be 1.5 to 2 times of midbrain and medulla. So that here we can see that this much, totally the morphology is altered, and the normal angulation of the pons and midbrain forwards is totally lost, and the midbrain is rotated backwards. This is a tectum. This is the midbrain totally rotated backwards, and the extent of the pons, this is the extent which is shortened, and the posterior part of pons, that is the tegmentum, it is not a true straight line. It is interfered by a protrusion into the fourth ventricle. So normally the posterior part of the pons should be a straight line, and also it should be here in this case it is interfered by a protrusion into the fourth ventricle. And also the normal appearance of the pons ventrally is lost. In our case, it is totally flattened out in the ventral aspect. So this is the inference of the brainstem, and also there is poor pontomedullary differentiation, and medulla appears to be lengthened. And assessing the vermis, we can see that the vermis is hypoplastic. Normally to infer whether it is hypoplastic, we should draw a line between the intercolliculi, that is between the superior colliculi and the inferior colliculi. That is a line drawn between the two colliculi, and also from the obex. But here, as obex is the lowermost part of the fourth ventricle, it is because of the total angulation of the brainstem. Actually, we cannot use this as a parameter to assess the cerebellar hypoplasia here. But since the CSF space around it is more prominent, and also it is lying above the clavum, it is definitely hypoplastic. That is, the cerebellum is hypoplastic. So, and also we have already described that this it should be a straight line, and the fastigium, that is the midpoint of the fourth ventricle, that is the apex of the fourth ventricle, it should be just below the midpoint of the ventral part of the pons. That is a normal anatomical configuration which is totally lost in our case. So from the mid-sagittal view, also we can infer that the posterior fossa volume is reduced. Usually this is a normal appearance. The tenting appearance is totally lost, and it has become a more acute angle with a low-lying torcula. So the posterior fossa volume as such is reduced. The midbrain is rotated backwards. The ventral part of pons is flattened out. The pons has become short, and there is a protrusion noted from the pontine tegmentum into the fourth ventricle with the poor pontomedullary differentiation, and the vermis size, it is hypoplastic. And looking into the supratentorial anomalies, the corpus callosum appears to be thinned out. Going to the parasagittal view, the cerebellar hemisphere usually should be occupying the full of the posterior fossa, but here we can see it is occupying the posterior fossa volume is reduced, and in addition to it, the CSF space is prominent here. So there is, in addition, cerebellar hemisphere hypoplasia. So going into the coronal sections, this is flare section and T1 section. So here we can see this is a normal appearing MRI in this level, where we can see the middle cerebellar peduncles on either side protruding on lateral sides. So here totally we are not able to appreciate the middle cerebellar peduncle, and the cerebral peduncle here. The normal appearance is it is flared out. It is somewhat abnormal here. The cerebral peduncle shape is abnormal. So there is, in addition, some midbrain morphology alteration also, and middle cerebellar peduncle is not appreciable in this images. And also we can see that the hippocampal morphology is altered. That is bilaterally, right more than left, it is altered. The normal morphology is not present. And going further towards the superior cerebellar, we can see that this is a normal appearance of the superior cerebellar peduncle. So here we can see that it is shortened and thinned out. And here we can see the cerebellar hemispheres normal MRI we should appreciate well. In our case, the cerebellar hemisphere is not appreciable, especially on the right side. It is appearing as a rudimentary cerebellar hemisphere. And going further, posteriorly, we can see that the cerebellar hemisphere is rudimentary, and we can see here that the folia actually we cannot comment because it is not so clear. Usually the fissure should be radiating towards the cerebellar nuclei. So these are the T2 axial sections showing that the pons is flattened ventrally. Into the fourth ventricle, there is a protrusion. This is again showing the ventral part of pons flattened and the vermis is hypoplastic. The cerebellar hemispheres are very rudimentary. And also the lateral horn, the morphology is altered. It has got a wavy margin and pointed edges. And these are the images. These are the flare images which we have already seen. The MRS was normal. So based on the imaging findings, the main crux of the lesion is in the infratentorial area. So these are possible congenital posterior fossa malformations which can be divided into 4. That is predominant cerebellar involvement, cerebellar and brainstem involvement, predominant brainstem or predominant midbrain. Here in our case, it is both cerebellum as well as brainstem involvement. So concentrating into the cerebellar pathology, whether it is a hypoplasia or an atrophy. So hypoplasia, the fissures will appear normal, the interfolial distance will be normal, and the posterior fossa volume will be less or normal. And if we are repeating MRI, it will have a stable appearance. And in hypoplasia, the shape is maintained, only the volume is reduced. And in atrophy, what happens is that there will be interfolial distance gets enhanced, that is enlarged, and there will be a varied shape. The shape will be altered because of preferential involvement of lobules. And if repeat MRI is taken, it will be a progressive atrophy, and the posterior fossa volume is usually normal. So in our case, it is probably at this point of time hypoplasia, but we cannot actually for certain tell that it is hypoplasia. Only on repeated MRI we can tell if it is evolving into an atrophy or remaining as a hypoplasia. So cerebellar hypoplasia at this point of time, the child has hypoplasia, can be again divided into unilateral or with mainly vermis involvement, or both vermis and hemisphere involvement, or a pontocerebellar hypoplasia, that is with pons involvement. So in our case, it is probably with pons, cerebellum, and both involvement, along with other brainstem, that is medulla also is involved. So unilateral, there is the causes are infection, infarction, trauma, and post-surgery. So going into the pontocerebellar hypoplasia, the cerebellar hypoplasia can be again divided into dragonfly type and a butterfly type. In dragonfly, it is mainly indicating that the vermis is relatively preserved when compared to the cerebellar hemispheres. The cerebellar hemispheres will be the wings of the dragonfly, and the body of the dragonfly will represent the vermis, which is relatively preserved. So both vermis and cerebellar hemispheres are involved, but vermis is relatively spared. It is typically seen in pontocerebellar hypoplasia type 2, 1, and 4. While in butterfly type, the cerebellar hemispheres are relatively preserved, while vermis is more involved. But for our child, it is neither of these two phenotypes. It is both vermis as well as cerebellar hemisphere involvement more or less equal.
Elizabeth, can you make it a bit more fast so
Yes,
that
ma'am.
Joy can comment?
Yes, ma'am. So the imaging findings are hypoplasia of the ventral part of pons with ventral flattening, a tissue protruding from the pontine tegmentum into the fourth ventricle. The shape of the medulla oblongata is altered. Near total absence of middle cerebellar peduncles as well as other superior and inferior cerebellar peduncles are thinned out. There is backward angulation of midbrain and thinning of corpus callosum. And the main forest we are dealing with is the pontocerebellar hypoplasia, but that is just the radiological diagnosis, not the etiology. While trying to analyze, we should analyze whether vermis or cerebellar hemisphere, which is more involved. If vermis is more involved than hemisphere, it more indicates that it is a neuronal migration disorder. If cerebellar hemispheres are more hypoplastic or more or less equal to vermis, it is more suggesting a pontocerebellar hypoplasia as in our case. So the phenotype is pontocerebellar hypoplasia. So the imaging approach, first we should rule out non-genetic causes for pontocerebellar hypoplasia like infection, disruptive causes like prematurity, and after that we should analyze the infratemporal and the supratemporal anomalies. In infratemporal anomalies, we should rule out specific patterns. So the pattern recognition is more important. That is specific patterns. One is non-lobulated cerebellar vermis, which is very typical of VLDRL as well as Velen type of mutations. And dragonfly pattern, as I've already mentioned, is typical of 1, 2, 4 PCH types. And brainstem grooves are typical of alpha dystroglycanopathies. Cerebellar cortex hyperintensity is typical of PCH7 as well as congenital disorders of glycosylation. Cerebellar cysts are very typical of alpha dystroglycanopathies. Brainstem kinking, they are typical of tubulinopathies. So all these patterns, none of them were present for this child. So actually going further to the supratemporal anomalies, there was no agenesis or simplified gyral pattern of hypomyelination or calcification or megacorpus callosum. So going into the pontine pathology, here in our case, the child had a flattened pons. So these are some of the genes enumerated by Rush et al. So these are some of the genes, that is MACF and MAST1. Both of them are associated with megacorpus callosum. ARFGEF2, which is associated with predominant infratemporal anomaly with lengthened midbrain as well as inferior vermian hypoplasia. And pontine tegmental cap dysplasia, which is more suiting for this child. The ideal, the first and foremost diagnosis is pontine tegmental cap dysplasia because there was a cap-like protrusion into the fourth ventricle, and also other genes like RTTN, WR8, 1, and CYP2A. So,
can you conclude, Elizabeth? Can you conclude?
So in view of the flattened pons, as well as the protrusion into the fourth ventricle, as well as other brainstem anomalies, the probable diagnosis of pontine tegmental cap dysplasia was made. So putting together, this was the diagnosis, that is pontine tegmental cap dysplasia, and these were the cardinal findings in our case. So this is a signature pattern, radiology pattern of tegmental cap dysplasia, and this is the normal appearance, and this is our index case. So we can see this is a normal appearance where the isthmus is at an acute angle, while in tegmental cap dysplasia, it comes to be more at an right angle. And what happens is that the midbrain gets rotated backwards as in our case. And also there will be a cap-like protrusion from the tegmentum of pons into the fourth ventricle, and the vermis will be hypoplastic, and the ventral part of the pons, there will be a loss of protuberance, there will be flattening, and there will be loss of pontomedullary differentiation.
You can point to the cap in your MRI once more. Just last one. Okay, just show that gap which is protruding.
This is a gap.
Okay.
This is which is protruding into fourth ventricle.
Dr. Bijoy, we'll hand over to Dr. Bijoy now.
Okay, ma'am.
Thank you very much. So this imaging finding is pretty much characteristic of pontine tegmental cap dysplasia. But one thing, I'm not sure whether these are classified as pontocerebellar hypoplasia. Even radiologically, I don't think we can call them as pontocerebellar hypoplasia, because they are specific entities where you see the dragonfly or a butterfly or a bee-like appearance is seen, where there is not much of a brainstem kinking, but rather brainstem hypoplasia as well as this thing. For example, tubulinopathies are not classified as pontocerebellar hypoplasia, except one of them, the PCH6 type or so. But that is because it has got a specific appearance on pontocerebellar hypoplasia. And the other thing I want to tell is that this imaging, for example, in my neurometabolic disorders, you have to add a spectroscopy, because many times you will not be very specific, but the case we have seen, second case, sometimes you can make a very specific diagnosis. Like that, if you see any brainstem or cerebral anomaly, you have to always do a diffusion tensor imaging color map. So in this case, it would have shown abnormally oriented transverse pontine fibers, absence of decussation of superior cerebellar peduncles, and absence of middle cerebellar peduncles fibers and all. So those things is very important. So when you are seeing, radiologists should real time see that, and actually there is no point in giving contrast to everybody. There is no point in actually giving constant imaging protocol for everything. So we should decide what to do. So if you see a brainstem abnormality, always do a DTI. If you see a metabolic disease, always do a spectroscopy. So with that, I think we'll conclude, and like to thank both the speakers as well as Dr. Mini for coordinating, and AOCN for giving this opportunity. Thank you.
Okay, over to you, Dr. Kaushik.
Thank you, Dr. Mini and Dr. Bijoy. We are extremely grateful to you for conducting this session on such a short notice, and it was such a very, very fruitful session. And I would also sincerely thank Dr. Elizabeth and Dr. Merin for presenting excellent discussion. And trust me, it was a 1 hour wonderful journey for learning. So it's very pleasant to hear and learn from Dr. Bijoy, and we are extremely grateful to you, sir. Thank you very much for everyone for attending the session.
Thank you.
Thank you, Dr. Mini. Thank you, everyone.
Thank you.
Thank you. Dr. Kavita, Dr. Anaita, do you want to add any?
No, nothing from my side. Thank you very much. Excellent session.
Excellent session. Brilliant. Thank you.
Thank you so much.
Thank you very much,
everyone.
madam.
Good night. Good night. Thank you so much.
Good
Thank
night.
you.
Bye.